invite Dr. Kashipa Harit ma'am for the next session on global standards and benchmarking stroke management. She is the Deputy Director of NUH. In addition to this, she is currently functioning as Program Head of Ayush Initiation and Project Head of Digital Health Standards in the organization, including Vendor Solutions Program of NHA. Program in charge of full accreditation of healthcare organizations like hospitals and small healthcare in NABH and NABH International since 2013. Over to you, ma'am.
Fantastic presentation right now, and Dr. Nirmal has touched very important topics, which I might be saying it, but obviously not in the same comprehensive manner as he has touched upon. So to begin with and not wasting much time, I'm Dr. Kashipa. I am working, I've been part of NABH for its last 12 years. And thank you once again. And just to begin, can
you put the slideshow?
Yeah, ma'am.
Okay, doesn't matter.
No. Just a second. I'll just put it. Just give me one more second. Yeah. Is it visible now?
Anyway, it is visible. It's visible. You continue.
I think I put it in a slideshow. I don't know if this is a slideshow or not.
It's basically you'll have to read the layout now.
Yeah.
It is showing the slide layout and things like that. That needs to be minimized. Otherwise, the slide is visible.
Just a sec.
Maybe do the play. Just click the play button.
Okay, just a sec. Sorry, because this was not my system today.
It's in Keynote slide show, so you can just click the play button, which is up.
But the slide is visible better. We can continue.
Can I just continue with this if it's okay with everyone?
Yes, it's continue.
So I'm just going to take 1 minute of introducing NABH to the audience here. So NABH is part of Quality Council of India and what Quality Council of India is again part of Ministry of Industry and the Ministry of Commerce and Industry. And it was set up in 1997, Quality Council of India. So under the aegis of Quality Council of India, NABH was basically configured in 2005. And this is the past very proud thing that I'm going to say, that is such very senior people have been part of the chairpersons who are of Quality Council of India, beginning with the Honorable Mr. Ratan Tata sir. So under that, NABH has grown in leaps and bounds, and Gracie ma'am has been associated with us since the beginning. So we are lucky to have her also all the time guiding us. And currently our chairperson is Dr. Jakshay Shah, and our Secretary General is Mr. Rajesh Maheshwari. And this is the overall governing structure of Quality Council of India, under which we have 5 boards. And under that 5 board, we have NABH, which is basically accreditation body in the country, which is also one of the largest bodies, just second to probably USA in ISQA, and where we have touched upon almost 14,000 healthcare organizations all over the country, under the categories of certification, accreditation, and empanelments. And NABH basically it accredits all the healthcare organizations, right from as small as dental clinics to blood bank to bigger hospitals to the allopathic hospitals and to the Ayush hospitals, and lately even the Ayush health and wellness centers. So this is a very big project which we are doing, wherein all the health and wellness centers across India, 12,500, are also being certified by NABH. And it is a prime project of Ministry of Ayush. So coming back to the main topic, that NABH is basically creating a healthcare ecosystem. So under that healthcare ecosystem, why stroke care units are important, and why we are moving from a basic overall healthcare organization to standalone standards like eye care organizations or for stroke. So thank you, Dr. Nirmal, for touching all the topics, wherein we began from how pre-hospital care is very important, and the prevalence of stroke lately has come up to almost 42%. And basically what he mentioned was, correct me if I'm wrong, that 1 in every 4 minutes is one patient who's actually getting stroke in India. So to see the overall demographic and the prevalence and the incidences of stroke, NABH thought of coming up with the stroke standards. So just to finish the slide here, we are also ISCO accredited, and up till 2026. Ma'am, it's clearly visible now, my strike. So basically coming back to NABH standards for stroke management, how sir has mentioned about the challenges. I'm going to pick up a clue from what Dr. Nirmal ended his presentation with. So basically, he very clearly delved upon things like what is required overall in a stroke management unit. So we begin with pre-hospital care, then we move on to the emergency care, then we move on to the neuroimaging, followed by recanalization or the treatment where there's thrombectomy and thrombectomy is done, or thrombolectomy is done. Then stroke unit care directly is done, then the rehabilitation, and vis-a-vis, again, simultaneously having a hub and spoke model wherein to reach out to the tier 2 and the tier 3 places. So covering of all these gamut of things that sir has mentioned, that due to the current prevalence of stroke, India being a developing country is actually having a double burden of non-communicable diseases, wherein stroke is also one of the most ignored, but one of the most prevalent ones. So keeping all these things in mind, NABH standards cover all these aspects. Slowly in the next 15 minutes, I'm going to basically cover how these standards cover the pre-hospital care, how what sir mentioned, how it helps in strengthening the emergency department, how what sir also mentioned is that training aspect. Like in Tamil Nadu case study, it was mentioned that how MBBS doctors and MD medicine doctors are also trained for treating and identifying the stroke patients and also giving them treatment in first 15 hours. The golden period, as they mentioned in the stroke care. So all those aspects in a detailed manner are covered in each of these chapters going on, as we say. So as simple as how pre-hospital care is there. So in the first chapter, I'm coming up with one case study wherein the first, sir has also mentioned it, so there might be a little bit of duplication here, that the median inter-hospital transfer time for stroke patient needing targeted therapy is 174 minutes, which is longer than the recommended 120 minutes. So this is one of the international case study which I have cited here, wherein sir has already mentioned about the ones which are done in India as well. So the most important aspect here is identifying the symptoms, ensuring that the patient is being taken to the hospital. Thirdly, informing the treating team that the patient is coming immediately and to be treated directly and not wasting much of time in identifying the symptoms or transferring the patient. So all those aspects of this clinical care, of pre-hospital care and transferring to the emergency department is basically taken care in our first chapter of AAC of NABH, wherein the overall intent of the chapter again is how the patient is transferred, who is taking care of the patient, how early is the initial assessment done, who is taking care of the initial assessment, in how much time the patient is enrolled in for the any diagnostic imaging or neuroimaging, if the hospital is having the trained staff for conducting the neuroimaging, again it's covered in the next chapter as well. So all the first chapter, what sir mentioned, basically all the other aspects which sir mentioned about pre-hospital care, including the emergency care, are stepwise in a process manner covered in first chapter of NABH, wherein it overall covers the strengthening of the emergency services as well. So so the focus of the stroke care and the stroke centers is primarily to enhance the stroke care service, the delivery care of the stroke patients within the hospital. There, we might take a bit of a time to specially have standalone stroke units like how we have CCUs, as I mentioned. But by focusing on this particular aspect of certification of standalone stroke units within the hospital may help us in clubbing the loops, clubbing the gaps, which my predecessor, both the senior neurologists have mentioned. Similarly, another study that we found somewhere was that a standard patient pathway should include assessment of neurological impairment, vascular risk. So basically, this overall case study primarily focuses on identifying the correct diagnosis, the person who's handling it, the person who is knowing that when to give thrombectomy and thrombolectomy, the training of the doctors who are attending to it, and all the management, the stroke care pathways, the standardized stroke care pathways, which are basically a benchmark which has been used in various other countries. All these aspects are covered in our next chapter, which is called COP, care of patient. So care of patient primarily focuses on how the patient is treated. What are the guidelines, are the specific guidelines implemented as per the protocols? Is the staff who's attending to the patient is trained enough to attend to those is trained enough to attend to the patient in a particular manner? Availability of resources, both in with respect to man, money, manpower. The rehabilitative services, as Sir was really emphasizing on the rehabilitative services post stroke. So, as one of the things I had noticed was that 42% of the physicians lack awareness in treating and also identifying the symptoms of stroke. So, this particular chapter basically clubs, rather strengthens the whole process of clinical care, clinical pathway, strokes protocol, what is followed within the hospital. So all that aspect in a structured manner is covered through the COP chapter. This also thing when Sir mentioned was something as rehabilitation. So we have a separate standard only focusing on how the patient is rehabilitated, who's doing it. Is the patient given correct nutritional therapy at the time of rehabilitation? Because if you notice that there around average age of stroke patients now has fallen between the age group of 30 to 45, which is economically very viable population. They are the economically empowered population. So the economic impact of stroke is very high, especially when patients are almost 22 to the tune of 20 to 22% are falling into this age bracket. So hence the focus on rehabilitation should be more and more constructive. But if we see, except the tertiary care hospital, the smaller hospitals, the hospitals which are in tier 2 cities, the hospital which are in tier 3 cities, or for that matter, the hospitals, the bigger hospital, the smaller hospitals within our own cities, the cosmopolitan cities like Delhi, Bangalore, Mumbai, most of them do not take stroke patients inside. I will just cite one very small example, which happened with a relative of mine. Immediately when they had stroke, they were rushed in the heart of the city. They were rushed to one particular hospital. I'm not going to mention the name. And since they did not have any trained doctor who could even give them initial therapy of thrombolization, the patient was transferred to a different hospital, which was almost 45 minutes to 1 hour away. And given the Delhi traffic, I'm sure it must have taken more than 2 hours. So see the repercussion of not knowing, the patient doesn't know if the hospital is stroke ready. Once they reached, then the hospital staff was not competent enough to take the patient in. So all the crucial time was lost. So keeping all these aspects in mind, COP chapter and the rest of our chapters are where once the hospital is stroke ready, it brings about the awareness within the patients as well that this particular hospital is cardiac hospital, or this particular hospital is stroke hospital. So that kind of awareness we need to bring in once we introduce quality within the stroke units, or the strengthening of the systems within the hospital for the stroke units. So another example which we saw in one of the places is, it's a very common example about the wrong medication which was given to one of the patients for thrombolectomy. So the third chapter, I'm not going to delve much into it, but it primarily talks about the management of medication within the hospital setting. Wherein, so in this specific stroke standards that NABH has launched, here we specifically identify the availability of these thrombolectomy and thrombectomy specialized medicines which are available. Secondly, it also covers the aspect of the doctor being trained and knowing how to dispense that medicine. That is the specific aspect which is being covered here. Another case study which we found, or rather challenge which Sir Dr. Nirmal Sir has already mentioned, is about contributing factors and family-centered care model and encourages collaboration and partnership among patients. Another aspect is the financial burden that it incurs. So economic impact, Sir has already mentioned, I'm not going to repeat the same thing, but the economic burden with respect to treatment of stroke patients getting admitted within the hospital, the treatment cost incurred by the patient, the treatment cost incurred by the healthcare society as a totality part of the healthcare is immense. In fact, in places like India and other places, it's not even really talked about. Most of these studies are based out of India, which I don't know if they're very much mentioned here, but one of the categories which only study which I was able to find was the one wherein the least one was rupees 50,000 as a financial burden. So if the patients know, and if the doctors know, and as the sir mentioned, the community participation is more. Similarly, incorporating the digital aspect, wherein incorporating the hub and spoke model, these kind of economic impacts can drastically be reduced. So similarly, our chapter on patient rights and education covers these aspects in a very predominant manner under these stroke standards. I'm not going to talk much about the hospital-acquired infection, though, because we all know that any patient who is basically a stroke patient is usually, there's always a scare of bed sores. There's always a mental issues around it, infection control practices which are dealt within the hospital. So we found there was also a certain concern that smaller hospitals they are not stroke ready at all. So the trained nursing staff, in fact, the nursing staff which are trained for handling the patients, they are not aware or they do not know how to prevent bed sores, which is also the biggest challenge for patients with stroke who are not able to move very fast or rehabilitate very fast. So those kind of aspects about the trained staff, the training of the nursing, the training of the paramedics with regards specifically regarding treatment of rehabilitation of stroke patients is something which we have covered in this particular chapter. So another thing that we have spoken and we all talk about in quality is patient safety. So it is commonly reported that 1 in 10 hospitalized patients experience harm, with at least 50% being preventable. And around 2/3 of all adverse events resulting from unsafe care and the years lost to disability and death occur mostly in the LMICs. So Sir has already delved upon the data which is primarily there, that most of the Southeast Asian countries have the higher burden of stroke in our country, in all the Southeast Asian regions. And non-stroke units are almost to the tune of 72%, if I'm not wrong. So more than 40% cases are reported from Southeast Asia for the treatment of stroke. So they're not trained. People are not aware. So to come back to the quality system here, the first and foremost is to bring about awareness. Second is to bring about the trained staff. We all passed MBBS, but we were not trained. Let's be honest, we only knew how to identify the systems of stroke, but even the MD doctors do not know how to initially do the thrombolysis of the patient. Thrombectomy is a much later thing, which is obviously. But none of the people who pass out in our current healthcare system are usually adept to handling stroke patients. So the basic and the main forte or my main focus of our healthcare quality system, or the quality systems per se, should be training of doctors. And now that doctors should not be DM per se, because it's very difficult to get the DM doctors everywhere. So we should focus on training the MBBS doctors. We should focus on training the MD doctors. We should focus on training our paramedic staff. And thirdly, we should focus on training our own nurses to identify and to also at the same time start initial treatment and to raise the red flag, that how to go about doing it. Because as Sir mentioned, that more than 42% of the physicians aren't aware that when to transfer the patient, when to refer to the patient. That's a huge, almost 42 doctors out of 100 doctors that pass out every year. That's a huge number that we are facing as of today. So the next chapter, I'm not going to get into this PSQ, but the next HRM is primarily focusing, our main chapter, HRM, is focusing on these aspects: training of relevant staff. Training is not just as for training and retraining. And so that is one aspect that we need to plug in to make our country stroke ready. Similarly, we also, my previous speakers also spoke a lot about the development of the infrastructure. Now, in that case, infrastructure is a huge thing as with regard to stroke, we may say. So again, within this, if we want a stroke unit to be functional, say, for example, in a place like Bareilly, or something as simple as peritanmata. So in that case, all our hospitals wherein we have MD doctors, then we have to make our emergency department stroke ready. We have to ensure that all the supplies of the medicine, including the the oxygen and other things, need to be ready. So in that case, the focus should be FMS chapter, which talks about availability of the CT scan within the vicinity. The patient should not be taking too much of time to get the CT scan done, and the reporting. So all those aspects again are covered in a very detailed manner in this. Another thing which we need to talk about is in a lot of places, and the incidents I'm going to tell you, certain places we saw when we were doing a pilot or something, the hospital is willing to treat the patient. The doctor is also there. The DM neurologist is available within the hospital, but there's no CT scan available nearby. So that's a huge challenge. Again, presence of diagnostic or neuroimaging facilities within the hospital or within the vicinity, wherein the correct diagnosis can be reached on. So again, this particular aspect, once clubbed in, can again introduce a quality system or strengthen the stroke units within the country. So thirdly, which the last human resource I've already touched upon. This is a very, very important aspect that we need to strengthen. Hub and spoke model has already been spoken about. Places like, we have tertiary care hospital like PGI Chandigarh, AIIMS, who are already running this telemedicine program of stroke, wherein they are attached to various smaller hospitals, and timely the doctors in those areas are also trained by the main doctors sitting in their room in the heart of the city. So telemedicine plays a very important role. Technology integration, as mentioned. So with the advent of digital standards, which we have launched recently, this amalgamation within the hospital is something that we are really looking forward to. So this amalgamation of telemedicine, teleradiology, technology integration, strengthening of EMRs, strengthening of HIS, training through digitization, hands-on training through digitization is something which is dealt upon across our digital standards vis-a-vis various aspects. But specifically coming with the stroke standard, this is going to be a game changer eventually next 2 to 3 years, because this is in certain tertiary care countries, hospitals, this has already been planned and it's already been conducted. And the example that Sir gave was that Tamil Nadu one and the Himachal one is itself an example of the stroke successful workshops. Then thirdly, that we talk about with regard to technology, stroke, specialized stroke units with regard to resources. Now, these resources, as we mentioned in previous slides here, is something resources where NABH plays its role comes from, again, material, manpower. So all the standards primarily are, they help in strengthening the system, right? So in strengthening of system means what? The healthcare strengthening of system with regard to resources, and resources can be your doctors, your paramedic staff, your infrastructure, the pre-hospital care, including the emergency medicine, including the equipping your ambulances, ambulances for picking up the patient and as part of the pre-hospital care. All those aspects, right from the patient getting a call, the hospital getting a call from the patient that we are having stroke symptoms, and please send an ambulance. From that aspect to clinical care, to stroke pathways, to rehabilitation, how the doctors are trained and delivery of care, and again training. All these aspects are clubbed, or rather addressed in these standards that I'm currently reflecting on the screen. So all the aspects which is, and whatever challenges which Sir mentioned, once the hospital comes and makes themselves stroke ready, and even if comply for almost 80-85% of these standards, I guess we will be reaching what all our seniors have mentioned in the morning, just before my presentation. So thank you so much. I guess this is what I'm going to end here. And thank you so much for giving me this opportunity. Thank you, ma'am. Thank you, Kaho. And I'm going to end my presentation here.
Thanks, Dr. Kashipa. It was a wonderful presentation.
Thank you. Thank you so much.
Thank you, ma'am. Thank you for your